One, we are live.
All right. Good morning, everyone, and welcome to our November Group Insurance Commission meeting. I am Valerie Sullivan. I am the chair. I am joined by our group of commissioners and our GIC staff, as well as some guests. So today's agenda is packed. I want to say hello to all those who are watching live stream and welcome you to today's very exciting commission meeting. At this point, Andrew, if I could ask you to list out, besides myself, Valerie Sullivan, Chair, who's at this meeting, I would greatly appreciate it.
Of course. Joining us today are our Vice Chair, Commissioner Kaplan, our ANF designee, Martha Kwasnick, our designee from the Department of Insurance, Rebecca Butler, Commissioner Choate, Commissioner Edmonds, Commissioner Gentile, Commissioner Guerin, Commissioner McEnany, Commissioner Murphy Rodriguez, Commissioner Tim Sullivan, and Commissioner Kaplan West.
Excellent. Excellent. Well, thank you, Andrew. And at this point, I'd like to turn the meeting over to Matt, our Executive Director, to give us a flavor of the agenda for today.
Thank you, Madam Chair. We can move to the agenda slide. Thank you. We'll be using today's meeting to discuss healthcare affordability, first broadly in Massachusetts, and then specifically as it relates to the GIC. That is really the focus of this meeting, and of course, it's very, very timely. So we're happy to have David Seltz, Executive Director of the Health Policy Commission, who will start with an overview of healthcare spending in Massachusetts and some words about trends that we're seeing in the marketplace. Following that, we will have Jim Rust, our CFO and Chief Procurement Officer, provide a more focused view of healthcare affordability from our lens at the GIC, some of the challenges that we're facing and some of the solutions that we are looking at. We will not have a CFO report today, just given the kind of relatively early timing of this meeting and the data that we have available, but we will provide you that report or an updated report at our December meeting. So this really is, as commissioners know, this is kind of the beginning of the process of our rate setting and plan design discussions as we prepare for our fiscal year 26 coverage that will start on July 1st. And we start with this really as level setting and context to the challenges that we face and that we'll be looking at in more detail in the subsequent meetings that we have. So there's 2 items on the agenda, but as the chair notes, it is a busy agenda nonetheless. With that, Madam Chair, happy to turn it back to you for action on the minutes from the last meeting.
Thank you, Matt. And I am very excited that we do have the Health Policy Commission here. I know that we as a commission are very committed and want to see this data and also see if we can use our clout in the marketplace to drive some meaningful change that's measurable on cost. Maybe not for next year, maybe for next year, but definitely trajectory forward moving. So thanks in advance for pulling this on the agenda. So at this time, I will take a motion for approval of the minutes from our meeting in September. And it feels like a long time ago, but the minutes were well written. So do I have a motion?
So moved.
It sounded like it was Bobby and Eileen or Jane. But
Me.
okay, Jane. So I do have that. So I'm going to ask Andrew to do roll call, but I am a I. Andrew? You might be on mute.
I'm sorry, I was. Commissioner Edmonds, was that a second to the motion?
Yes. Yes.
Okay. Chair Sullivan, you were affirmative?
Yeah, yes, I was.
Okay. Vice Chair Kaplan.
Yes. Aye.
Designee Guanza.
Aye.
Designee Butler.
Abstain. I was not in attendance.
Okay. Commissioner Choate.
Abstain, not in attendance.
Commissioner Edmonds.
Aye.
Commissioner Gentile. I know he was having trouble with his technology. Commissioner Guerin.
Yes.
Commissioner McEnany.
Aye.
Commissioner Murphy Rodriguez.
Yes.
Commissioner Silva, who has joined us.
Yes.
Commissioner Tim Sullivan.
Yes.
Commissioner West.
Yes.
And just to give Commissioner Gentile an opportunity if he's been able to get online. All right, well, the motion passes by majority.
Thank you. So at this point, let's turn the meeting over to Matt and move into the substance of a terrific, I know, meeting.
Thank you, Madam Chair. First item would be a quick review. Actually, we'll start with the Executive Director's report. Each of you will have received the written report ahead of the meeting. I'll highlight a few items from that report. And on the staffing front, we welcome a new employee, Joan Chase, who will be working in the operations department's audit unit. She brings a strong background in benefit administration and has worked in municipal government. She has, interestingly, worked as a GIC coordinator at the municipal level. So we're delighted to have Joan bring that experience and perspective to the team. So welcome, Joan. Also, just a brief update about our telephone language translation service, which is called Language Line Solutions. We introduced that earlier this year. So our operations team representatives on the phone are now able to arrange for solutions when we have a member who reaches out to us whose first language is not English. And translation services are available through this capability in 380 different languages. It's proven valuable to our members as we do get multiple calls a month needing this type of service. I will note that the most commonly requested languages are, of course, Spanish, followed by Mandarin. We've also had calls translated into Farsi, Italian, and Amharic. So this is a feature that we've had available in the past, and you know, a really important element of our ability to continue to interact with, engage, and support our members who speak a variety of different languages. I will also note in the report that the work on the reduction in the waiting period project continues and is going very smoothly. Commissioners will, I think, be happy to know that we have nearly 4,000 newly enrolled members who were new hires to the Commonwealth and the variety of other agencies that we work with. And they have benefited from, you know, much more quickly effective coverage as they start their employment in the public sector here. So we're really excited by that. The team has continued to monitor that very closely, and all is going well there. I will note just one other item which did not include in the written report, but commissioners may have read news coverage of contract challenges that our carrier Point 32 has had with a variety of different providers. We are in close touch with the leadership at Point 32 about this. I think these these tough negotiations represent a really growing challenge that our carriers face in negotiating rates for healthcare services that are sustainable here for us at the Group Insurance Commission. We have heard of rates that are substantially above the benchmark. We'll talk a little bit about this a little bit later in the meeting. So as I've said in prior meetings, I expect that we're going to see more of this. And the potential for disruption for our members with a contract termination, the risk of that is also growing. So we work with our carriers to make sure that we're communicating to our members about what this may mean for them and their healthcare. So we've had a few calls that have come into the office looking for guidance here. And should this contract or these contracts lead to termination, again, we'll be working very closely to make sure our members know what it means for them and what they can do. So I just wanted to add a note to that because there's been some press coverage. With that, I'm happy to pause, take any questions that you may have on any of these items.
Matt, I don't see any questions. I did see a lot of enthusiasm for the number of stakeholders and constituents we've served with a reduction in waiting period. So that's really good work. I think it's meaningful to just anybody who's listening, quite honestly, because with it's so hard, or at least it appears in the marketplace, so hard to get good talent, retain talent, the cost of finding talent. What the GIC has done is made it, I think, easier, or at least one less objection for someone to join a state role, because having to wait is a lot of work, and a lot of cost. And so I just want to make sure we pause for a moment and understand that work that's been done, especially stakeholders. Maybe it's easier to have new people join your agency now because of the work that's been done. So I'm super excited, Bobby. I'm sure you're going to echo what I'm saying. I personally think that we should have some sort of deep dive press release on it, but at the same time, we have very humble executives at the GIC. So anyways, Bobby, take it away. And then I'm eating into the agenda, which is something I generally don't want anyone else to do. So I'll be quiet.
Thank you, Valerie. I will echo what you said because this has been a boon to our, to state employees, and of course to other, GIC members of. It's such great news, and it's been terrific that people now have health insurance essentially on the day of hire, which is terrific. It's, decades in the making, and I know how much work and how much effort and that everyone at the GIC has made to get this implemented. So kudos to everyone on that. Um, we're hearing, just from lots of employees how terrific that is. So thanks again, everyone. And I just want to ask a question, Matt, regarding the Point 32 Health, um, and the providers. Um, are you, I'm assuming, providing like guidance to people who may not be able to like join that same network or see their providers that they've been seeing for a long time. So um, is there the communication that's going out or to members of Point 32 whose contracts might be expiring?
Yeah. So we are ready to, we being really Point 32 with our support and coordination, are prepared to send out communications on this. We remain hopeful that an agreement will be reached between Tenet Healthcare and Point 32. That is typically the way these resolve. So we are ready should that happen. And Jim, if there's anything that you want to add here, please come in behind me.
I think that's right, Matt. They have a plan to create continuity of care where necessary and to be in touch with the members and to have dedicated resources for those folks to contact them if need be. And we continue to talk to them. We talk to them every week about this, to see where they're at.
Thank you.
And I do think it's important to note too that, you know, if an agreement is not able to be reached here, we have confidence that the Point 32 network continues to be robust enough to preserve access to necessary services.
All righty. Well, thanks for being on top of that. It's not surprising given the challenges in the marketplace from a cost perspective. So appreciate being kept abreast of that. So at this point, I don't see any more questions. So let's keep moving. Take it away, Matt.
Okay, so let's take a quick look at the calendar. Not a lot new here as we approach the calendar year's end. We'll begin, as I mentioned earlier, to focus on plan design and rates for the upcoming fiscal year 26 plan year. The first step will be in December, where we present the commission with the FY26 preliminary aggregate average cost increase that we project. We'll also bring to you the dental and vision procurement, our recommendation for a vote to the commission, as that work has been ongoing for several months now. In January, we'll present the plan design recommendations and a report from the stewardship meetings that we have ongoing now with all of our key vendors. And we will hold, as we always do, our annual public information sessions to socialize the recommended plan design changes and to gather feedback from our members on those changes. We will also be adding, as I think I mentioned in the spring meeting, we'll be adding over the next several months additional items to the calendar that follow up on our presentation in our September meeting on our health equity initiatives and our behavioral health access initiatives. We want to continue to keep you informed of those. So you'll see those fill in some coming calendar agenda items. With that, I'm happy to take questions.
I don't see any, so let's keep moving.
All right, with that, I'm delighted to once again welcome David Seltz, Executive Director of the Health Policy Commission, to present to you today. I just want to say a few words before handing it over to him. As I've said before, we're very fortunate in Massachusetts to have the extraordinary resources of the Health Policy Commission and the Center for Health Information and Analysis, CHIA, and to have them led by such serious and thoughtful minds as David and Lauren Peters at CHIA. The data-driven insights that they provide help us all understand what's happening in the healthcare marketplace, and with a special focus really on our three strategic priorities being affordability, health equity, and behavioral health access. We have a great deal of alignment across our agencies with those priorities. I really strongly encourage commissioners, each of you, to read through the annual cost trends report that the HPC issued. It really paints a picture, I think, of two colliding crises in our healthcare system. On the one hand, we have a delivery system that's struggling with the impacts of the collapse of Steward Healthcare, but also persistent workforce shortages that are driving up labor costs and potentially endangering access to care. We heard at the cost trends hearing last week providers warning that the healthcare system is in a fragile state, and the strong challenges that they face to maintain access to care. So you have that crisis on the one hand. On the other hand, we have a sharply escalating affordability crisis, and I think it's important to call it that. Hospital and physician groups are demanding some extraordinary rate increases in their negotiations with carriers, far in excess of the cost growth benchmark. Add to this the wave of high cost drugs, or wave after wave, really, of high cost drugs that continue to wash over budget projections for those who pay for insurance as we do. And at a time on prescription drugs when the HPC still does not really have the statutory tools to monitor those trends in the ways that we really need to. So in my view, these developments, these colliding crises, really threaten the core promise of Chapter 224, which is that our spending on healthcare not exceed the growth of the overall state's economy. And from where I sit, I believe we've entered a new, really more dangerous phase of our affordability challenge. We struggle with it as a plan sponsor for 420,000 people. It impacts our budget and our reliance on the general fund. Our members struggle with rising premiums that eat into their modest public sector wages and pensions. Everybody who's paying for health insurance is really struggling to sustain the cost here. So in addition to its analysis of healthcare market trends, the HPC has put forward a series of policy recommendations to really help policymakers chart a path through these crises. These crises really, they're system challenges, as we've often talked about, and they really require system level solutions. It's exceedingly difficult for individual actors in the marketplace, including the GIC, even as large as we are, to really handle these and create solutions to these. So my hope is that policymakers will act with the urgency that is really demanded of this crisis, and in specifically to look at the recommendations that David and the HPC team have put forward. So with that slightly long introduction, I wanted to give a little bit of context from my seat. I'm happy to turn it over to David. Thank you so much for joining us.
Thank you. Good morning. Thank you, Matt. Thank you, commissioners of the Group Insurance Commission, Chair Sullivan. Thank you for inviting me to be able to present this morning. Matt, that was, I think, a great introduction and a really succinct kind of overview of the tensions, of the colliding crises facing our healthcare system. And I really couldn't have said better myself. So I think I'm done. I don't really need to even present. No, actually, I will be sharing some data that I think is going to just really reinforce the message that Matt just laid out for you. Before I start my presentation, though, I did just want to commend the Group Insurance Commission on the topic that was just mentioned earlier around the first day coverage for state employees. We at the HPC, we are a GIC covered state agency. It is meaningful when we're hiring So thank you. And it is no small thing to be able to do that. Kudos to you and kudos to the organization. It's great for state government and it's great for the people who want to work in public service. So thank you for that. To start my presentation, next slide, please. Next slide. So, the Health Policy Commission, we've been around for 13 years now, and I often still feel like I need to introduce ourselves, even though I've presented before the Group Insurance Commission now for multiple years in a row. And it is always such an honor to be able to come every year and present this data. But just as, as a reminder, we were established as part of comprehensive legislation in 2012, really aimed at promoting affordability of healthcare in the Commonwealth through moderating the growth in healthcare spending. This legislation was really building off of comprehensive legislation that was promoting universal access to healthcare, Chapter 58, passed in 2006. Having made that promise to the residents of the Commonwealth and that successful effort to get everyone into health insurance and covered, the next big challenge really became, how do we afford that? How do we afford that in government? How does business afford that? How do residents and families afford that? And so policymakers really created a novel approach at the time by establishing this idea of a benchmark or a target to be able to measure and track the annual growth in healthcare spending in Massachusetts, and to have a target that we would all collectively work towards to moderate that growth. To help lead that effort, the legislation also established a dedicated expert agency in the Health Policy Commission that would look at the entire healthcare system and work with the entire healthcare system to meet those goals. And so we at the HPC, we look at all parts of spending, Medicare, Medicaid, and the commercial spending. We look at all parts of the delivery system as well as the insurance side. And so really, as Matt said, really taking that system-wide lens look. And there really there was never a state agency really across the country that had that kind of system-wide view. I want to spend just another minute just talking about the benchmark on the next slide. It's a prospective target, and I want to be clear that it is not a hard cap or regulatory limit. It is something that the state can exceed and has exceeded, as I'll show you in just a minute. But it really is something that is trying to motivate the market to work towards. We do have an ability to hold individual health plans or health systems accountable to their own performance to meet the healthcare cost growth benchmark. And if we find that a health plan or a health system has exceeded the healthcare cost growth benchmark for their own spending, and that threatens the state's ability to meet the benchmark, we can require that they do what's called a performance improvement plan. And this would be an 18-month kind of plan to implement strategies to bring their spending in line with the benchmark. Again, I would just note that we are looking at total spending across all categories, including spending out of pocket by patients. Really, the only spending that we're not capturing here as we look at this is true kind of out of pocket spending, over the counter spending, or if people are paying kind of out of pocket for services not through the insurance system. Next slide, please. I just want to share our mission statement because I think it's important to note that while affordability and moderation of cost growth is core to our mission, that can't be at the expense of the other values that we hold in the Commonwealth. And so, as the last part of this mission statement says, our overall goal is better health and better care at a lower cost for all residents of the Commonwealth. We can do all of those things. We do not need to sacrifice the great quality care, the great access to care, the innovation that we have in Massachusetts to be able to moderate the growth of healthcare costs. We can find those strategies that do all of these things and do it for all residents. And so the for all residents really is a statement of commitment that of health equity that is core to being able to be successful in our mission. Next slide, please. Just a minute about our structure. We are an independent state agency, and I report to a board of commissioners, not unlike the Group Insurance Commission. It is an 11-person board, and the board members are appointed by the governor, the attorney general, and the state auditor. And we have the two ex officio members are the Secretary of A&F and the Secretary of Health and Human Services. Each of these members, they are citizen experts who volunteer their time essentially to the work of the commission, bring a certain viewpoint and expertise to the work of the commission, as you can see here. Health economist, expert in behavioral health, expert in purchaser of health insurance, et cetera. In addition to that, I also have a 30-person advisory council that I work with quarterly that represents the perspectives of the healthcare system. And so here I work with the Mass Health and Hospital Association, Mass Association of Health Plans, all of the different associations and organizations that represent different parts of the healthcare system to really be able to get their viewpoints incorporated into the work of the commission as well. Next slide, please. We were the first state to have this idea of this benchmark to try to bring healthcare costs in line, as Matt said, with the overall growth of the state's economy. But we are no longer alone. There are now 8 states that have established healthcare cost growth benchmarks, and 1 in 5 Americans live in a state that has something like a healthcare cost growth benchmark. So like Chapter 58 and our efforts on universal access inspired the Affordable Care Act in the US, our efforts here have inspired these 7 other states to similarly take up the innovations that we pioneered here in Massachusetts around efforts to promote affordability in their states. I would note, in addition to these states really taking on this work as well, some of them have gone further, and some of them have even put in place more innovative policies than Massachusetts. And so Matt mentioned a little bit earlier about some of our policy recommendations that we have put forward that we would like to see action in Massachusetts. Some of those recommendations are inspired by what we're seeing in other states that are moving beyond Massachusetts. So I think there is an urgency for policy action if we want to maintain our longstanding leadership position in health policy across the country. And I should have said this at the beginning, commissioners, but if you have kind of questions along the way or want to interrupt me, like raise your hand or wave me down. Like I'm totally fine being interrupted, and also fine. We'll all save some time at the end for questions. So sorry, I should have said that earlier.
Okay.
All right. Next slide, please. So just how do we as an agency try to influence the healthcare system and the healthcare market to meet these goals? Well, we have a couple of different levers. We do a lot of research and reporting, as I'll show you in just a minute. We also partner with healthcare organizations. We've invested close to $100 million over the last 13 years in community hospitals and community providers, allowing them to test and innovate new ways of delivering care. Many of those investments have been in areas like behavioral health and substance use disorder innovations. We're a convener We are humble in knowing that we do not have all of the answers to these significant generational challenges in healthcare. And so part of our role is really bringing people around a table together to collaborate and discuss how we can take collective action to find solutions. And so just last week, we had our cost trends hearing where we worked with and sat with and asked questions of the top leaders and CEOs of the major health systems and health plans in Massachusetts and asked them questions under oath about their efforts to meet the state's goal. And finally, we act as a watchdog on behalf of the public. And here we monitor the business of healthcare in Massachusetts and the changing business of healthcare. And here we review mergers and changes in acquisitions, the consolidation of our delivery system. And what we know that when there are those changes in the business of healthcare, that there are impacts that happen on cost, quality, access, and equity. We have a role in trying to understand what those impacts may be and reporting those both to the public as well as to the Attorney General's office and to the Department of Public Health to help inform potential enforcement action or conditions on those market changes. All right. Next slide. Let's get into some data. This is my favorite part. All right, next slide. So first, a broad overview. So we've been at this now for a while. And so here is our performance against the benchmark over the last 10 years. So each of these bars represents the state, an annual growth rate for the state for each of these time periods. For the first 5 years, you can see the comparison to the benchmark is the dotted orange line, and the annual average performance is the blue line. So you can see for the first 5 years, our average annual growth was 3.4%, below the benchmark of 3.6%. For the more recent 5 years, you can see that the benchmark went down slightly to 3.1%, while our performance, however, increased. And so over that time period, our average annual growth was 4%. You can see clearly a huge disruption with the pandemic. 1 year of negative spending growth followed by a year of very high spending growth. That is really a reflection of some of the closures of inpatient services, the disruption of our healthcare system during the first year of the pandemic, and then, of course, a rebound in those services in the second year. Interestingly, if you just kind of average those 2 years out, it averages out to about 3.3% average annual growth. So it looks like a big swing, but if you kind of smooth things out, it doesn't look as disruptive. But nonetheless, one of the things we're concerned about is this acceleration in recent years, and are we seeing a trend that is going to continue into the future? And unfortunately, we see a lot of warning signs that it is, and this is going to be a really growing concern for us moving forward. Next slide, please. So I'm breaking this down, and here for many of these slides, I'm going to be showing growth from 2019 to 2022 averaged out, kind of smoothed out, again, to just kind of smooth out the disruption of the pandemic. And here I'm breaking it down by market segment, commercial, mass health, Medicare Advantage, and Medicare fee-for-service. And just to show you that really the segment that is growing the fastest is in the commercial market. Below that, you can see enrollment changes during this time period. You can see that enrollment in commercial insurance dropped during this time period, but really the spending growth, this is average annual growth, 4.7%, was in the commercial market. That's really where we're seeing the driver of the spending growth overall. And that's really where we're going to be focusing a lot of the data that I'm going to be showing you moving forward is in the commercial market. Matt, did you want to say something?
Just something briefly, just to note that these are, these are years past, of course, for GIC, and the 4.7% increase for commercial for that time period matches and tracks with what we were seeing at that time as well.
Great. Next slide, please. So again, just focusing on the commercial spending trend. Here we're comparing Massachusetts to the United States. And you can see Massachusetts is in orange, the United States trend is in blue. And you can see that beginning in 2012, which was when the law was passed, that orange line dips below the blue line for many of the years, meaning that the Massachusetts commercial growth rate was below the US average growth rate. And so on the one hand, this is a good story, and it clearly says that something changed with the passage of this law in this market. However, I think what concerns me is where we're seeing that divergence start to close. And in more recent years, we're seeing Massachusetts start to exceed the United States. And again, starting to project into the future and what we know, some of the headwinds are in 2023 and 2024, again, a concern moving forward. Eileen?
Yeah, good morning, David, and thanks. You know what, can we go back a couple of slides? I just had a question about kind of the COVID years, right? And I know you're averaging them out because COVID was atypical. What I'm trying to understand is we also know that during COVID, the federal government poured lots of money into the healthcare system, knowing that they couldn't do, any kind of optional or discretionary healthcare, right? And so I guess I'm just wondering, like, is that amount of money factored in? Because the notion was to make them whole, and I'd like to get a sense of if that's factored in.
Yes. So the COVID relief funding is factored in here. And I can give you offline, I can give you a sense of kind of the scope and scale of that.
Okay, that would be great. And that's mostly in the 2019, 2020. So even with all that federal money, the spending went down that much.
Yeah.
Okay. Is there any kind of chart that shows the corresponding expenses? Like, did they go down too because people weren't getting care? Again, I'm just trying to get a sense.
Yeah, so this is the spending that was occurring. So I think if we wanted to look at kind of the financials of the health system and kind of the operating revenue versus expenses, that would be a different analysis. But I don't have that with me, but that is something that I could share with you.
That would be great because I think that is what is said to be driving a lot of the cost. It's a lot of the makeup, right? And would just want to get a sense of kind of the base coming out of COVID.
Yeah, yeah. And on the financial side, those relief dollars did play a significant role in helping to keep the margins and kind of the balance sheet of our health system from a huge negative during these years.
And I would say just briefly from the GIC's perspective, we were seeing warning signs, particularly as it relates to provider pricing and rate negotiations before COVID hit. So there clearly have been impacts on the system from a cost and other perspective that were caused by COVID, but there were trends that were concerning before, and at the time we were concerned that they would, while temporarily being masked by lower utilization during COVID, would reemerge as we come out of COVID. And I think that's what we're seeing.
So let's let's skip forward a little bit. And yeah, next slide. So this is just a slightly different calculation, but it again is just showing that commercial spending growth compared to some other benchmarks that we may look at to try to understand what's happening here in Massachusetts and if we should be concerned. So on the far left, it's as I said, slightly different calculation, but 5.2% commercial spending growth per enrollee annual over this time. That is much is higher than what was happening in the rest of the country. It's higher than family income growth in Massachusetts during that time, and higher than the benchmark. We often, look at family income growth as an important figure as a comparison, because especially in the commercial market, when we see healthcare spending growth growing much faster than income, that can often lead to premiums that grow much faster than income, resulting in just less take-home pay for residents and employees. This is a dynamic that you know very closely at the GIC. When premiums go up faster than income, it comes right out of the employee's pocket at the end of the day. Next slide. So wanting to understand a little bit more about going underneath that figure, where are the categories of services that are driving that commercial spending growth? And so here we're breaking down that spending growth into some of the major categories of healthcare services. So I'm showing you kind of two time periods in the yellow and blue. The yellow is an earlier time period, 2017 to 2019, and the blue is the more recent time period. And you can see that the commercial spending growth was increasing, and you can comparing those two time periods, you see some very interesting trends emerge immediately. And the pharmacy trend is the one that just pops out immediately. 8.2% average annual growth during this time period, much, much faster than what we were experiencing previously. So that is a huge, obviously the number one fastest growing category. And we can also see that there was an acceleration in spending in the hospital services category as well. If you kind of follow that arrow across to the right-hand side of the slide, breaking the hospital services into its subcomponent pieces, we do see some kind of interesting sub-dynamics there, where it's really the HOPD stands for hospital outpatient departments. And so that is really the category where we're seeing an acceleration in spending growth. Less so actually on the inpatient side, where there's been actually a decline in utilization, and ED spending is kind of about the same. There's been a huge shift in some services from the inpatient to the outpatient setting, with advances in technology and care delivery. For example, hip and knee surgeries, 5 years ago were almost primarily an inpatient, you'd stay overnight type of a surgery. Now, the vast majority of those are done in an outpatient surgery, and you're home the same day. So that's been kind of a huge shift in care delivery that we see in the data now. Next slide. And here we're then breaking it down into price versus utilization. So are we using more of these services, or are we spending more for the same number of services? And on the left-hand side, we're showing the change in pricing. And here you can see that it really is the change in price that is the major driver of the changes in spending for these different categories, and very much so for prescription drugs. It is not that we are using a lot more prescription drugs. It is the fact that the price of those drugs is increasing at a very rapid pace. On the right-hand side of the slide, you can see changes in utilization during this time period. Very, kind of small changes in utilization. And in the case of inpatient stays, actually down. Yep, Eileen.
Thanks. So between the previous slide and this one, is one of the takeaways that more like office-based care, like primary care visits, for instance, are taking place in hospitals. So I know that there are more day surgeries and so forth, but it also looks like from the previous slide, if you could go back one slide. So see the third bar from the left where office and urgent care retail, it's way down. And then the outpatient at the hospital is way up. I guess what I'm trying to determine is has there been a migration from a lot of the services that used to take place outside of the hospital into the hospital?
I think I don't know that we have a perfect answer to that question, Eileen, but I think you're asking the right question in so much as just to kind of play out the dynamic a little bit. If care is moving generally from an inpatient setting to a hospital outpatient department, generally that's going to be cost saving to the system. But if care is moving from a doctor's office, or to a hospital outpatient department, that's going to be cost increasing to the system because we know that a lot of routine care is being delivered in hospital outpatient departments in Massachusetts. That is a known thing about our system that differentiates us from the rest of the country. That we do a lot of what in any other state would be just done in a doctor's office is done under the license of a hospital office in Massachusetts. And in many cases, patients don't even know that they're going to a hospital outpatient department because it looks like an office building and it's not connected to the hospital in many cases. They would have no idea. And yet, due to the fact that it's operated under the license of the hospital, there's, as I'll show you in some slides, significantly higher pricing attached to those services. So I'll show you a little bit of that dynamic, Eileen. And I think the question that I can't quite answer is how much of that migration is happening versus it's already happened and it's kind of continuing to grow. Vice Chair Kaplan.
Yep. Thank you. I have a question regarding like virtual visits. If you notice a trend, I know it was, trending very high during the pandemic, and I'm wondering if that has leveled off, if you've seen a decrease, particularly in primary care visits.
I think the last time I looked at that data, I think we did see for primary care telehealth visits that was coming down and that more of that care was returning to in-person visits. And that, it definitely peaked, kind of in the heart of the pandemic, and that really was starting to level off. It was still it's at a much higher rate than it was pre-pandemic, but it really was starting to more return to into in-person. What has stayed at a very high level is virtual mental health visits and behavioral health visits. That has stayed and has been really, really sticky at a very high level. And so that has been a significant change that clearly patients and residents prefer that modality of being able to interact with someone for having that type of mental health care. And so that's my latest recollection of kind of the trend lines, but I could probably get you some more up-to-date data.
Yeah, and that is reflective of what we're seeing as well, reported to us from our carriers. Behavioral health, sticky, primary care, some erosion over time.
Right. No, thank you for that. I have one more question, which I'm just sort of curious about because there have been a number of articles recently about first of all, the lack of primary care physicians, the impact of that, and also that many primary care in particular are moving to boutique services.
Yep.
And I'm curious what you think the trend, I mean, it seems to be trending in that direction and what the impact of that would be, for us, for our members.
Well, I will say, and I have a slide on this a little bit later, but just to share now, um, the proportion of money that we spend on primary care in our healthcare system is going down. We are spending less and less of our healthcare dollar on primary care in this state. Um, we know that the wait times for primary care um, in Massachusetts and in Boston are among the worst in the country. There's one survey that we have of major metropolitan areas. Boston had the second longest wait times for a primary care visit. Um, and we're seeing in erosion, and I think I've been following the news as you have of people, primary care physicians moving to concierge or boutique, and part of that motivation is that they are burnt out of the current healthcare system and not compensated appropriately. We don't pay primary care providers nearly to the level that we pay other types of clinicians. We don't value their time nearly to the same that we do others. Our healthcare system just does not value primary care. And I'm personally very concerned about this trend, Vice Chair Kaplan, because when these physicians make that decision to move essentially out of to a model where patients have to spend $5,000-$10,000 to just have access to that physician outside of the insurance market. That is, we're setting up a tier of care for the haves and the have-nots, even more so than we have today, and it exacerbates the primary care problem. Because in many cases, and I'm hearing this more anecdotally than I have the data for, but those physicians, when they make that move, they may be also reducing their patient panel size, and so not only are they moving um, into a different kind of business model, but they're also maybe seeing less patients, understandably. But what that means is even greater challenges for everyone else. And so this is a really concerning dynamic. And the governor at our cost trends hearing really highlighted this as an area that she was going to be focusing on next year in her administration. And I think one that all of the state health agencies are kind of taking up the challenge to say, what do we need to do here? Because when people don't have access to primary care, they put off care that they need. It exacerbates illness. They sometimes end up in the emergency department when they don't need to be there, which leads to even more costly care, and which is, again, contributing to what we know is happening in our hospitals, which is a backup in the emergency department, a backup in capacity. So I think I went off too much on that, and I'm sorry for getting on my.
Oh, no, you
I'll
did not,
apologize.
Madam Chair.
Sure. Jane, go ahead, and then I know
No,
Annie had her hand up too.
David, I'm just very grateful that you quote went off on that as you did, because it crystallized, I think, for many of us, many of the people listening, just what you're describing as the seriousness of that issue. You say it's a trend, and it's a trend that's getting worse in your own opinion.
It's terrible. Yeah.
Yes. Yeah. Yes.
And what you're really describing is the ripple effect of the harm or potential harm that can happen as a result of the arguably undervaluing of primary care physicians
Yeah.
as
Yeah.
it affects patients and their care, the quality of their care.
Absolutely. And we see it throughout the pipeline. medical residents are not choosing to go into primary care or internal medicine or family medicine. When you have that much educational debt, and you look at the salary of a primary care physician versus other specialists, so we need to think of this like from the very beginning, kind of throughout this pipeline. So I agree. And for all of our goals on health equity, we're not going to be able to meet them unless we have a strong primary care foundation. Anna?
Thanks. I just wanted to comment. I just think this is a comment more than a question. This is just excellent presentation. Thank you
Yes,
so much.
it is.
And I think this slide in particular, um, just being able to break down where we're seeing this growth as potential targets for intervention is hugely helpful. It makes it all more actionable. So thank you.
Yeah. And I want to double click on that, Anna. And thank you, David, but also ask a question. And I can't seem to figure out how to raise my hand. So I'm raising it. I loved that you said that the governor at the cost trend hearing committed to this challenge with a reduction in primary care. And maybe my hypothesis, I'm just going to hypothesis too quick that, if we have a reduction in primary care, therefore more specialists, more, higher cost care, therefore, the costs go up, and a reduction in prevention, which then makes costs go up. Um, you know, Wondering what, if anything, you can share with us what the governor's commitment was. Like, are there some actionable things that you think we can do in the state to drive more primary care, residents or, medical students to select primary care? Anything that you can share with us on actionable deliverables that we could do, or at least that you're noodling around, would be, I think, inspirational to me.
Yeah, thank you. It's a great question. And I think part of the governor's challenge was for all of us to really come up with those solutions and to come to the table um, willing to compromise, to say that this is an important goal and that we need to reorient our system to value this important part of our care, because it just does not right now. And it's clear that the market forces themselves and the financial incentives themselves aren't there. Just underline a point you made, Chair Sullivan, in Massachusetts, we have a lot of physicians per capita, probably no surprise. But we have the lowest proportion of primary care physicians to specialists of any state in the country. So we have way more specialists to primary care physicians if you could just kind of look at the share. So we are very much a specialist heavy state compared to primary care. I think there's things that other states have done here. Just as we've set goals for moderating the overall cost growth, other states have set goals to say, let's do that. But at the same time, let's set goals for actually increasing the dollars that we're spending on primary care. And let's ask our carriers and our health systems to work towards that goal and to, over time, put a little bit more of the healthcare dollar into primary care to over time, be able to kind of shift those financial incentives and turn that dial a little bit, to be able to give these practices and these doctors a little bit more of the financial resources that they need to be able to support their practices, to be able to support their care.
Yeah.
That is a model that Delaware, Rhode Island, Oregon, California, all of them are working on this. And because I'll just say, in the commercial market, 7.7% of our healthcare spending is on primary care. less than 10%, 7.7. So you could increase that spend on primary care pretty quickly just by kind of moderating the growth on everything else, right? You don't have to even cut anything else. You could just, if you just moderated the growth of everything else, you could put more money into primary care. That's one idea. The other thing is the administrative burden that is being placed on these physicians. For every hour of clinical care time, they have to do 2 hours of documentation.
Oh,
So,
yeah, for that.
this is about, are there ways that we can think about um, automation of prior authorization, more standardization on some of the utilization management, or some of the different administrative bureaucracy that is being placed increasingly on these physicians, that is contributing again to some of the dynamics of leaving the profession or going into concierge. And I think we have to think about the pipeline and what does it take for to support residents who want to be working in this field, to commit to primary care, to be trained in primary care, and then to stay in Massachusetts to practice. We train a lot of physicians in Massachusetts through our incredible medical schools. A lot of them end up leaving. Part of that is due to the broader affordability challenges of living and working in Massachusetts. But can we think about, especially with the primary care physicians we're training, how can we think about supporting them and staying and practicing here in Massachusetts?
Well, those are good points. So I want to make sure we're discussing and having questions answered, David. So I'm going to ask Eileen and then Catherine, and then we'll keep moving. And we still have enough time, right, David?
I can hit the highlights.
Good.
So,
all right, go ahead, Eileen.
Sure. So, very quickly, I just wanted to share to underscore David's point. Front page of the Wall Street Journal recently was about how most medical students, particularly women, not most, but an increasing number, are going into dermatology because they can make $500,000 a year, work 3 days a week, and have a work-life balance, and they're foregoing primary care. So if we don't think this is like a real dynamic, it's front page of the general media. So I do think that we need to focus on that. And I will just say, a couple of years ago, then Governor Baker had filed a bill that required more money to be spent on primary care within the confines of the cost benchmark. And I think we need to dust that off and really think about it. And I do think the new CEO of Lawrence General testified recently at a forum about how there's still a lot of waste and inappropriate care in the system, still roughly about 30%. So we could kind of advance primary care with a little tightening of the belt on some of that other stuff.
All right, good, thanks. Go ahead, Catherine.
Thank you.
Our newer commissioners speaking up. I love it. So thank you. Go ahead.
Thank you, Chair Sullivan. Good morning, David. I'm wondering if you can speak to hospital outpatient, and certainly this slide and the next slide really speaks to a concerning trend, and second to pharmacy. And the premise, as you know, for hospital outpatient was we're going to decrease costs if we shift from inpatient to outpatient, and that will overall decrease costs. But we're seeing the opposite here. So I'm wondering if I'd love to hear your policy recommendations, and also to the chair's point earlier, what are some practical things that we can consider as we look at this space?
Yeah, thank you for that. I think the concept of paying more for the hospital outpatient department, really started in the Medicare program. And, I think there was, at its core, this concept that, this was care that was going to be provided, potentially right on campus, next to the hospital, and that, that the care being delivered benefited from, the potential support of the hospital in case there were complications in kind of the services being provided. what has happened over time, however, is that what we've seen is that many of these hospital outpatient departments are not on the campus of the hospital. They may be many miles away. And what is, many of the services that are being provided in these hospital outpatient departments are very common ambulatory services, primary care services, evaluation management services, lab tests, screenings, things that are often very much done in any other office, physician office in the Commonwealth or in any other state. And yet the payment rates are much, much higher. And so what do we do about that? We have recommended, and this is a recommendation that MedPAC has also made on the federal level, is we need to equalize these payments because and pay the same rate, not pay that extra rate essentially. The extra rate is sometimes called facility fees, and the kind of policy recommendation is kind of called site neutral payment, which is like let's pay the same rate regardless of where that site is. If it's the same level of care, the same services, we should be paying the same rate. Another dynamic here is that I'm sorry to keep going off on this, but patients don't know this sometimes, and they may be also they pay more out of pocket. They are having to pay more in their coinsurance or in their deductible, and they may not even know. And it also contributes to increased consolidation in our healthcare system, and increasingly, into these bigger health systems. So I think there's a lot of benefits to addressing, I would say, kind of the financial dysfunction of that payment policy, and we can do so in a way that that provides a more equal and level playing field. All right, I'm gonna try to hit a couple highlights and get you back on track for your meeting. So next slide, next slide. All right, main point on this slide is prescription drugs, branded prescription drugs are growing at a very fast rate. If you look at the last line here, 2022, you can go out, follow that line all the way to the right-hand side. That's the 90th percentile, 95th percentile, meaning that there's a small number of drugs that are over $7,000, $6,000 a prescription. This is increasing. So there's a high end of very expensive drugs, but also an increasing overall rate of branded drugs. All right, next slide. Next slide. So putting all of this together, where are we in Massachusetts? We have the second most expensive family insurance premiums in the United States, second to New Jersey. Next slide. And that average family premium is around $26,000. If you add in what people are paying out of pocket in their copays and deductibles, we get to about $29,000 for a family plan here in Massachusetts. That exceeds the cost of housing for in most parts of the state for a family now. So that is 1 year of family coverage, the total cost of that care. Now, families and residents are often shielded from that total cost of that care because their employer is typically picking up a great deal of that proportion of that cost. In this case, the employer is you, the Group Insurance Commission. You are picking up a great proportion of that cost on behalf of me, the state employee. And so I might not see that. Well, I'm not a family of four, but I may not see that total cost of care, but it is there. And it does impact the state's overall ability to be able to provide wage increases and other services. Next slide, as an example. I'll just, the next few slides just share a couple survey statistics which just say that Massachusetts residents are reporting increasing affordability challenges. This is that. Next slide, please. Increasingly are not getting the care they need due to cost. Close to 1 million residents in Massachusetts did not get the care that they need due to cost in 2023. These are affordability challenges are disproportionately experienced by non-white residents. Next slide. That is leading to increased medical debt for residents in Massachusetts. Next slide. And in no surprise, this is a survey, a very recent survey, 2024 survey. 2/3 of Massachusetts residents report being extremely concerned or very concerned about the cost of care. 40% surveyed said that they were putting off seeing a doctor or going to a hospital due to the cost of care. And I think, interestingly, the survey result that I found kind of, I think, most surprising here is on the bottom left-hand corner. When asked what is the most important issue in healthcare, residents said cost by a very significant margin, more than quality or even access. And I think cost and access can sometimes be conflated, because as we know that they're also saying that the cost of care is leading to access challenges. And so cost is what people are concerned about. And, this is a real challenge for the people who live here. And as Matt said, this is that colliding crisis with the real challenge that are happening in our delivery system at the same time. So how are we balancing these two tensions is, I think, the major theme of what came out of the cost trends hearing, and is the moment that we find ourselves in here today about how we find a path forward. We at the HBC have put forward some policy recommendations that we think can lead us that way. And I'm happy to talk about some of those, but I'm also cognizant of the time. So I'm going to stop here and just really leave the remainder of our time for some discussion and questions, and just know that I really appreciate the partnership and collaboration with the GIC, and know that we're a resource, and I'm not going anywhere. So,
David, if I just, before we hand it over to a few questions that have popped up, if you have a hard stop at 10, you have to leave us. But we could accommodate more time on our calendar. Don't want to put you on the spot or anything, but just to let you know that there's some flexibility on our end.
I don't know, Matt, if there were, the rest of my slides, if there was anything in particular you wanted me to hit on.
Yeah, I'll take a look at those while we answer some of the questions. Sorry, go ahead, Madam Chair.
I mean, I do think some of this data is, we've all said how amazing it is. If there is a way we could have you back to circle back and double click in some of these areas, especially around actionable tasks that can be done to, track a reduction, that would be great. So let's put a pin in that for your time, David, if possible, and ask Toby to go ahead and address his, have his question addressed, and then Eileen as well have questions, and I'm sure many may come up after that. So go ahead, Toby.
David, just curious, how much of the weight loss drugs, those Ozempic and like drugs, being used for weight loss? I understand there's an application with diabetes too, which is different. How much of that is driving the pharmacy cost? And maybe, Matt, you could chime in if we're seeing the same, whatever David's going to tell us about the general population.
Yeah, so we actually did have some slides on this. I don't know if we can advance to slide 29 in my deck here. Back just one. So this is the data that we have. We only have it through September of 2023, so it's a year old at this point. But this is the exponential growth that we're seeing in terms of utilization of these GLP-1 drugs. I expect once we have this next year of data, this is the percent of commercial members who are prescribed one of these drugs. I think that next blue bar is going to be probably double the size of that blue bar that you see there. And if you move to the next slide, again, just through September of 2023, we estimated around $270 million in spending. I suspect that will probably triple in 2024, and then will continue to go up. We heard at the cost trends hearing from the CEO of Blue Cross Blue Shield that of her growth trend. So she was projecting kind of a 10% growth trend in spending. That 2 percentage points of that was just to GLP-1s, just the weight loss drugs.
Yeah, and that matched what we projected for our current fiscal year. About a 2% of our 9.5% increase was attributed to projected spend on GLP-1s, and that has proven out to be true. And while there has been some temporary suppression of the utilization of these drugs, I think largely driven by manufacturer constraints, we have just seen over the last couple of months a pretty sharp increase in utilization. I suspect, again, because the manufacturing has been able to come online a little bit more of late. So I think the scale of your estimation here is about right.
Thank you.
It's a good concern. Go ahead, Eileen.
I promise this will be my last question.
Good.
And part of it is a comment. I want to thank you, David, for excellent information. And I want to thank you and Matt for framing this with the urgency that it requires and characterizing it aptly as a crisis. And I agree with you that this is kind of a collective effort because it requires systemic change. But I guess what I fear is that next year we'll be here talking about it again. And so I guess I would just ask you, who is best positioned to lead this effort for systemic change? Like, how do we begin?
Was that to Matt or to me?
Both, I guess.
Well, I think it, as I think was kind of talked about at the cost trends hearing, to me, this moment requires, a return to some of the tenor and commitment of the different stakeholders that we have had in the past, Eileen, where, the different groups have come to the table and been able to at least set aside some part of the self-interest of their own individual organizations with a viewpoint of trying to solve a larger civic problem. And that this is a civic problem that is impacting all of us and is threatening something that we all care a lot about, which is this healthcare system in Massachusetts and what it means for the people who work here, who live here. And the path that we're on, as I see it, is not sustainable. And when I see statistics that 40% of the people who live here are not getting the care that they need because of the cost of care in the most highest income state in the country, in the highest, income country in the world, in this state with our world-class institutions, that's a failure. When we know that Black women have 2.5 times the rate of maternal morbidity than white women, that's a failure. We have failures in our healthcare system, and so how do we bring people to the table to acknowledge that, and then be able to put aside their short swords and shields and say, how do we collectively find a path forward? You're asking who can do that? Who's the one to do that? You know, I don't know. I think the governor is, clearly had a strong message at the cost trends hearing around a focus on affordability and a focus on healthcare. I think it's going to have to be a little bit of a collective effort. And I am an optimist, and we've done it before. I think we can do it again. And so I will leave on that optimistic note, and I count on your partnership, Eileen, when the time comes.
And I would say,
I will
just
gladly
behind
partner.
that, David,
Thank you.
I think you're exactly right. And I think state government works best when we pull together those kinds of interests and focus and commit to real reform type solutions, right? And as I said at the conference at the Mass Association of Health Plans last week, these are system problems that really require system solutions. One thing we know about healthcare is that when you try to address a problem through one particular lane or narrow view of a market, it pops up somewhere else. We have a system that is, the cross subsidization of these challenges is profound. And look, entities like the GIC are well positioned to do some things innovatively of our own accord, and we have a history of doing that and an appetite to continue to do that. My preference is that whatever we do is aligned with what other players in the marketplace do, and so I'll leave it at that. But I think the general message, David, is exactly the right one. That this is going to take the same kind of collective effort, locking arms with all important stakeholders and committing to real change, because that's the only kind of seriousness I think that's going to really solve some of these problems.
Yeah. Well, that's well said, Matt. I think the general consensus of what I'm hearing from commissioners is, and maybe I'm putting words in our mouths, but we are the largest purchaser of healthcare in the state. So yes, it's important to lock arms. Also, for us to be leading the way for our constituents and for just fiscal responsibility, but also for our stakeholders. The numbers that you shared, David, in terms of the concern and the challenges with medical debt, it's just heartbreaking. And of course, heartbreaking, the disparities between white women and non-white. I mean, that's just silly and uncalled for in today's world. So let's see what we can do, and we welcome you back. I don't see any final questions. It's been a great discussion. any parting words? You probably, can give us, one or two pearls that you want us to leave with, so that we can do our jobs on behalf of our constituents.
Um, no remaining pearls of wisdom. This has been a really great discussion, and I encourage you um, to to be leaders, and you have been, and to continue on that path. You will have a cheerleader in me and the Health Policy Commission, and I look forward to being back to continue this conversation in the future. So thank you so much for having me.
Yeah, thank you.
Thank you, David.
Much. Have a good rest of the day. Appreciate your time.
Thank you.
All right. Well, that was great. I love to see so many commissioners engaged and asking questions. So thanks. Thanks to everyone for the interest and the commitment and our leadership, as David said. So at this point, I think we turn it over to Jim, or back to you, Matt, to turn it over to Jim.
Yep. And before I do that, just the remaining slides in David's deck, I think paint, add further clarity to some of the themes that we already discussed, which was the wide variation in pricing for the same service that continues to plague our system and represent real inefficiency, which ultimately is an opportunity for greater efficiency. And some more information about the hospital outpatient department dynamics, which we've discussed a good deal today and which we are thinking a lot about as well. The one slide that I would just call commissioners' attention to review is slide 31, on your own time, but the list of policy recommendations that the HPC has put forward this year, some of which will look familiar. There are some new themes here that acknowledge some of the more recent dynamics around Steward Healthcare, but you'll see a lot of these are recommendations that have been carried forward. And my hope is that we don't end up in a sort of circuit of looking at the same recommendations every year, and as a Commonwealth, we finally start to implement some of these. The time is now to do that sort of thing. So with that, I'll hand it over to Jim. I will just note, so the intent here was to provide kind of a coda to the message from HPC, to drill in a little bit more on some of our perspectives on the same dynamics that David walked through. I will note that, as others I'm sure have noted, that a lot of the data that David presented ran through calendar year 2022. I would say that since calendar 2022, we have seen some profoundly different dynamics. Not different dynamics, same dynamics with provider pricing and prescription drug prices that have simply escalated enormously. So we have the benefit of more recent data. For instance, on the GLP-1s, we're able to look at a spike in utilization and prescribing of those drugs in the last couple of months of the last fiscal year. So we have a more concurrent line of sight into these things. So with that, I'll hand it over to Jim to walk through the final portion of the meeting.
Well, Matt, I do want to just commend the sense of urgency. I think we all share it. So, it's our obligation here to deliver on that sense of urgency. So thanks for saying that. And Jim, I know you're leading the charge. So same to you, and hello. We
Hello.
give you enough time for your section.
Oh, no, thank you very much. I appreciate it. And, it's difficult to follow up David's excellent presentation, which, as you know, was more of a macro statewide treasure trove of data. But we have our outstanding data team here with Margaret and Lauren and also the vendor management group with Janine and Cameron, who also look at that data a lot when we manage events. So I just want to acknowledge that there's there's a connection there between us and them and what they do, and it's very valuable to us. Next slide, please. So as we start here, I just want to orient you a little bit. You may recall that the last minute we discussed our overall strategic framework for the GIC that supports the goals that you see here. And we're going to be back with you a few times this year to talk about our strategic work. So when we do that, we like to orient you around the goals of the GIC in general. And you see these, I know, in most of our presentations, so I won't linger. Next slide, please. Again, as a reminder, these are our strategic pillars. This is what we anchor all our strategic work to: behavioral health, health equity, and affordability. We also obviously prioritize our members in all this work that we do around these, as you can see in the guiding principles listed below. And again, this is just a refresher, and we want to frame our conversations through these strategic pillars whenever we can. Next slide, please. So today we're going to focus a little bit more on affordability. And as you just heard from David Seltz, healthcare affordability is a challenge at the local, state, and national levels. Many of these challenges can only be addressed at the state and federal level, but the GIC has had some success at the plan level in recent years. A couple of things we wanted to call out is you recall the procurement that we did a couple of years ago. We're starting to measure the success we've had there, and we estimate that the changes in the portfolio and the vendors has resulted in about 16 million or more in savings in FY24. So we feel pretty good about the work we did in the procurement. Doesn't mean there's more that couldn't be done, but it seems as though over the short term, at least, we've had some success there. Also, at the PBM level, while the pricing structure of the pharmacy industry, it continues to be overly complex, I'm sure, as you all know, if you're reading the same things I'm reading, and lacks transparency. But we do feel our PBM contract with CVS offers us strong discounts and rebates on prescription drugs, and we do benefit from the 100% pass-through of those rebates, which, if you recall from our audit presentation, we're going to harken back to some of those in other years that we've held our PBM and our plans accountable for that, making sure that we get that 100% pass-through that benefits our members and helps keep our rates relatively lower than they would be without that. I do want to point out that this does not insulate us from the ever-increasing drug prices that we all know are out there, but we continue to do market checks annually to evaluate the relative strength of our contract in the current market. So although the market may not be great, we want to make sure we have a strong contract in that market. We also hold our medical carriers accountable for year-over-year spending increases through financial performance guarantees, and we tie those to the benchmark that we just discussed. And we'll talk a little bit more about that in an upcoming slide. Next slide, please. Before we go on, here's a little more market context. I'm not going to do as good a job as David, but these slides look familiar because you just saw them from David. But as you can see from the top graph, the spending increases from 2017 to 2022 across both commercial and private insurance came in at an average increase of 4.4%, well above the benchmark. For the commercial market, the latest data, as Matt mentioned, is for 21 and 22 calendar years. The GIC's average increase was 4.6%. There are a few technical reasons and demographic reasons why all the spending is higher, including we have a bit of an older population and a higher risk score. But the overall point here, as David said, is that this is a market problem, and the GIC is part of that market. So we are in there with everybody else with these price increases and these price pressures. The primary driver of these increases at the GIC in the state continues to be largely provider prices. Next slide, please. So on this slide, I've laid out a framework for thinking about affordability. This framework is split into 4 areas. Participation, that comes down to who are our members, right? Cost sharing, and how are these costs split between the members and the Commonwealth? These 2 items, while important for analytics, are not really highly variable for us. Efficiency talks about how we can manage through unit price, utilization, and member engagement. So those are some of the tools available to us there. And vendor governance and oversight. How do we work with our carrier partners and hold them accountable to our strategic goals? This is what we spend a lot of time on. On this slide, as I mentioned, you will see the participation and cost sharing are grayed out. That's because our primary focus on our affordability work is on the efficiency and vendor governance and oversight at this time. Next slide, please. As you all may know, our members' participation is defined in statute. GIC's role is to ensure that the eligibility is documented at the time of enrollment, which we do well. And this process has become more streamlined with the investments that the Commission and the Commonwealth have made in the member portal. As mentioned earlier, in terms of demographics, our membership is 4 years older on average than the average comparable commercial benchmark, and our membership's commercial risk score is higher than average, 1.61, with 1.0 being the average. Both the higher average age and the higher average risk score are highly correlated with a somewhat more expensive population. For cost sharing, we know from our prime member surveys and our public information sessions that our members, by and large, prefer lower out-of-pocket costs to lower premiums. According to the Center for Health and Information Analysis 2024 report, GIC does have among the lowest cost sharing among employee-sponsored plans, and our plans have maintained a high actuarial value. We are committed to ensuring that our benefits stay robust and affordable for our member population. Next slide, please. Okay, so moving into efficiency. Efficiency is a primary area of strategic focus when it comes to our affordability work. You can see there are 4 buckets here on this slide that represent some subcategories under efficiency: out-of-network spend, site of care payment models, chronic condition management, and appropriate site of care for routine surgical needs. I'll briefly walk through these categories. So out-of-network spend. While the vast majority of GIC's medical spending is in-network, there are times when members receive care from a provider that is not contracted within the network. The resulting out-of-network bill can be several times that of the contracted rate. We are exploring ways that we might be able to standardize what the GIC would pay for out-of-network services. This is ongoing work. We don't have a program to roll out as of now, but it is something we're looking into. Site of care payment models. As we saw in the Health HPC's presentation, prices for common medical services, such as colonoscopies, can range from 50 to 100% higher based on outpatient settings than in other settings. GIC is exploring ways of constraining excess prices that vary slowly in the site of service. We could possibly do this through our next procurement or through contracting. We're also monitoring what other agencies, such as HPC, are doing in this area, so perhaps we could move in the same direction they are. Chronic condition management. There are a number of point solutions in the market where vendors offer condition-specific solutions for various chronic conditions. GIC, we meet with a lot of these vendors, looking to see if there are places that they can add value and benefit the members. By and large, we have not taken up a lot of these offers. But there seems to be a lot of evolution and activity in that marketplace, so we continue to monitor it and be open to the possibility of implementing some of these if they've added value and were beneficial to the member population. And finally, appropriate site of care for routine surgical needs. The GIC has looked in the past, along commissioners who've been here for a little while. I remember we looked at centers of excellence quite a bit a few years ago. This isn't something that we put on the shelf after the fact. We continue to look at this as a possibility of a way of attaining some more affordability while also benefiting members. We don't have anything that is ready to roll out now, but we continue to explore this possibility and have not eliminated as a potential initiative. Next slide, please. So governance and oversight. The GIC works closely with each of our carriers in our PBM to ensure not just that members are receiving appropriate care, but also that these vendors are doing everything in their power to contain healthcare costs. On this slide, we have 3 areas that will discuss our involvement in carriers with affordability. Transparency with provider negotiations. This transparency is both with having sight into the negotiations with providers in the contracts and also providing us with analytical data. Exploring new market offerings through the health plans and adherence to financial performance guarantees based on the benchmark that I mentioned earlier. So in terms of transparency with provider negotiations and analytics, we meet twice a year with the executives at each of these health plans. These are the stewardship meetings that you've heard us discuss before. We discuss plan performance, including expectations and the dynamics behind upcoming provider rate negotiations. These meetings are informed by analysis completed by both the health plans and by our analytical team here. So we both come to the table with our data and we discuss the differences and what the trends we see are. For example, in one recent GIC analysis of a carrier's rate increase, we dug into that and eventually met with their chief contracting officer who resolved our questions regarding how their rate increases were formed over time. So we really do get into the details with them. We'll brief you on the results of these meetings as we always do when these meetings are completed. They're ongoing now. We're kind of right in the middle of them. In fact, we have one tomorrow after, and we'll brief you on those in an upcoming commission meeting. In addition to these twice yearly discussions, we also meet bi-weekly with the account team and we discuss both member issues that are brought up to us and also contract negotiations and other issues that they may be having. We continue to see that contract negotiations are, as Matt mentioned at the beginning, going to be very challenging. We have more insight into that than ever before. And while we do feel for the carrier's spot in this, we also put a lot of pressure on them to make sure that they achieve the lowest prices that they can for us. Exploring new health plans. As mentioned earlier, we monitor the market for vendors who can provide quality services and help us contain costs. Our carriers are well situated to evaluate programs that offer them to our members. We have occasionally piloted programs for our carriers and then evaluate the results for perhaps adoption portfolio-wide. Our carriers bring us programs to evaluate and properly purchase through buy-ups. Like the point solutions I discussed earlier, we evaluate these from a quality and cost perspective. And finally, adherence to financial performance guarantees based on the HBC benchmark and the CHIA market data. The GIC has financial performance guarantees in all of our contracts. We expect them to keep the year-over-year increase of total medical expense at the HBC's benchmark, or failing that, we expect total medical expense to come in 1% under the year-over-year increase in the Massachusetts as calculated by CHIA. As you may know, unfortunately, for the last 3 years, with one exception, the carriers have not hit the HBC benchmark or the other measures. So we have collected on all these performance guarantees. Next slide, please. So finally, what's next on affordability? So since affordability is one of our 3 strategic pillars, everything the GIC does is viewed through that lens, along with behavioral health and health equity. We looked at affordability as a whole for both the members and the Commonwealth. As you have heard, we have some avenues to pursue this goal, both through outside vendors and our carrier partners, but the challenge is larger than this. As you heard from the HBC, the affordability crisis is felt not just by the GIC, but throughout Massachusetts as well as nationally. GIC's affordability challenges are real, and the staff continuously pursues ways to manage them with the tools we have available. And we intend to keep pursuing those affordability options through every means possible, including partnering with other state agencies like the HBC, who you just heard from today. And then with that, that's a high-level overview of our work on affordability. Again, many of these challenges, as you heard earlier from David, are market-wide and require large interventions, but there are things we can do in the plan level. I think it's valuable for the commission to know that we do work on this, and it's part of our daily mission, and we take it very seriously. So with that, I'm happy to answer any questions. I don't know, Matt, I don't know if you had anything you wanted to add.
No, that was good, Jim. I see Rebecca has her hand up. Hi, Rebecca. And then
Madam Chair, if I could just say a brief word before we go to
Matt,
questions.
I'm going to say a few words. Of course, that's fine. And then we'll go to Rebecca.
Yeah.
And then.
So look, these are substantial challenges. And as I said at the outset in introducing David, I think we're in a whole new phase of the challenge that we have at the GIC and others do of balancing quality of coverage, affordability of premiums, and cost sharing and access to care. And what we've presented here today, as you can see, we're relying on the tools that we have. And as Jim noted, we are constantly on the lookout for new innovations. We're looking at those that happen in the marketplace. We follow closely what our peers in other states are doing. And I want to assure you that we are shifting our thinking to reflect this escalating sense of urgency here. There's much more happening behind the scenes than we're able to walk through with you here today. But I am optimistic, as David said, that there's a growing acknowledgement of the problem here among policymakers. There's a desire to take a serious approach to it. It's going to take solutions of a whole new level of innovation and change here. As Jim noted, kind of changes in cost sharing and how we split these rising costs with our members through premium and through cost sharing ultimately is not solving the problem. It's about how do we spread the rising budget between the state and our members, but we're going to have to look at how and how much we pay for services, which we've traditionally done largely through our vendor carriers. This would be a significant shift for us, but we're actively working on a variety of measures. So more to come on this as always, but I wanted to add that additional note and turn it back to you, Madam Chair, for questions.
No, thank you. So as I noted, Rebecca has her hand up, and it's always so nice to have participation. So hello, Rebecca, go ahead.
Hello. I just wanted to let this panel and any listeners know that the Division of Insurance is planning its own sessions involving carriers and stakeholders starting on December 3rd. There'll be a 1-hour meeting where we discuss the role of the division in balancing solvency and access, but then we will have twice weekly or once weekly sessions through December into January on hospital rate increases, provider reimbursement, hospital provider utilization, pharmacy reimbursement, pharmacy utilization, administrative costs and related increases, discussion of policy options, and a session for new emerging issues or additional feedback on any topics. So those are not yet listed on our website, but will be shortly. And I'm happy to provide further information via email if anybody has any questions. But those will shortly be posted on the division website, and all are invited to attend. Thank you.
Thank you. Let's go to Toby and then Eileen, and thought I saw Bobby, but go ahead, Toby.
Jim, the efficiency list, under efficiency bucket, we kind of that's the ones we see annually, and I'm not being facetious or trying to be critical. I just think that they're probably the right tools, but if we're going to use those tools, we got to go big with them, because if we got to take some risk, and if it's a crisis, you take risks in a crisis. So I'm just saying is, you got to think that way. And maybe there's other tools. I don't really know, but those are the ones we see every year. And we know there's a lot of money in those. It's a good starting point. We know that other things about them. We just got to go big in implementing it, or try to implement it big and see what happens in the marketplace. So that's my only.
And I would say, Toby, that comment is very helpful to us, and it's been a theme that we've heard from the commission for a while, and it empowers us and empowers me and the rest of the team here to think about that next generation of tools.
But you may not be successful, or may not be successful in some areas and not other areas, but you got to try.
Yeah. I would agree there, and I appreciate the comment. I do very much that taking on more risk, given the challenges ahead, is much more part of the discussion than perhaps it was in the past and needs to be. So I'm agreeing with you, but that's
no risk, no reward.
Right.
All right. Hey, Eileen.
I just want to echo Toby's comment. I appreciate that we need to make some bold moves. And I also wanted to comment, I think it looks like the GIC is doing all that it can with respect to the management of pharmaceutical spend, right? It looked like a lot of your focus was there. What we know from the HPC is provider price variation is the other big opportunity area. And I do think we should think about somehow encouraging more primary care through the way we reimburse and having those conversations, certainly with our carriers.
Good, thanks. Bobby, bring us home, maybe. Are you on mute? No. Or did you? Hello?
No, I was on mute. No. I think the discussion today was like very insightful, as well as concerning, right? The trends. And so I agree with everyone that we need to possibly take very bold moves now, because the trends are just really concerning, for prescription as well as primary care. um, providers or the lack thereof. I'm curious if we know, like, if there has been a decrease in, or what that decrease is in primary care providers throughout our carriers, like if we have any idea.
I don't off the top of my head, but that's something I can look into. Yeah, that's data that we have. And if let me, I don't want to guess at it, but I think we can provide you that. Yeah.
And the HPC has done some really good work in this space, even just over the last 6 or 8 months. I'm happy to share some of the materials there that give a broader perspective, but Jim and I can look at it within the GIC's realm as well.
Yeah, we definitely are hearing about it from the plans. As we do these stewardship meetings, it's also part of that.
Thanks.
Yeah, I think looking into primary care, because again, my hypothesis is that potentially you drive prevention. We'd have to ask if there's strong data on that. But there are so many other ways that we might be able to make a difference here with the sense of urgency. So all really good questions. Thank you, Jim. Thank you, GIC. Thank you.
I see Martha has a comment.
Oh, Martha, how are you? I love this. We're having lots of engagement.
To wrap up.
Yeah. Good. Go ahead, Martha.
Yeah, I just wanted to note, I really appreciate the GIC's work in this area. I think as David Seltz had mentioned, and I think we've all acknowledged, the GIC and the service that they provide for all state employees is really meaningful. And so for them to take that affordability really seriously, I think says a lot about not just us as an employer, but us as a Commonwealth, and how we want to put that to the forefront and kind of share in those governor's goals of affordability. And look forward to the partnership and working on that. So that's all I wanted to add. Sorry.
No need, Martha. That was great. So thank you. So Matt, we have just a minute or so to do some wrapping, unless there's anything else on the agenda.
The only remaining agenda item, I believe, is adjournment and other business. But I will, before we wrap, just share an anecdote that really resonated with me. So I went to the pharmacy to pick up a prescription yesterday. Was standing in line next to a woman who was on the phone, an older woman, retiree, I believe, on the phone with somebody talking about her prescription. I don't know if it was her health plan or her provider. And this person, whoever was on the phone, was asked to ask the pharmacy how much the drug cost. And she did not fill her prescription. And as she was walking away, she was talking about the $150 a month cost of that prescription for her. And it was heartbreaking to watch. And I walked up just behind her, picked up my prescription. It was a generic drug, and I paid $1.73 for my prescription. To me, that sort of that reflects the really meaningful coverage that we offer to our members and how many others are struggling. And my hope is that we continue to have the kind of coverage that we do have, because it can be the difference between filling a prescription or not. And it was heartbreaking to watch, and just further motivates me. And I know the rest of the team is equally motivated to do whatever we can to keep the benefits, the kind of benefits, the type of benefits, the comprehensive coverage that we have in place. With that, happy to hand it back to you for any other business and adjournment.
Well, thanks, Matt. Yeah, I don't see any other questions. No other business from my end. I do want to thank all of the commissioners, the staff, our guest speaker, for the engagement. So I love seeing all the participation, and I would encourage us to continue to do that while also finding a date where we get together in person, because I miss you all so very much. And I hope I see you before the holidays. So except for, I know I won't see you before Thanksgiving, so I want to wish everybody a terrific holiday. Very grateful that I'm part of this amazing organization. So thank you all. At this point, I will entertain a motion to adjourn.
So moved.
All right. So I heard Joe, and then I heard Eileen. Or I think those were good. So I think I can take a group. All in favor, say aye.
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 Anyone opposed? All right. So then, with the power vested in me, I adjourn this meeting and send you off for the rest of your day. And again, enjoy the holidays. See you in December.
Thank you.
Happy Thanksgiving.